antigenic peptides, and we synthesized those peptides, and we injected those peptides into mouse and created hybridomas. Simply put, we created antibodies against this marker. And using these antibodies against this marker, we went back to the hospital. We actually collected CSF samples, designated CSF sample, and we ran those CSF samples on a Western blot, and our antibodies are highly specific, which detected this CSF, this LPDDS marker in CSF samples. So we have a tool to actually identify CSF, not the virus, just the CSF. Why we are planning to identify CSF? Because if we know that the CSF leaked out, then we know that there is a break in the central nervous system and which can cause infections. So once we know CSF leaked out, we can readily go and repair it. So what we did was, we did all these Western blotting and lab studies, and we've actually formed a test which can detect CSF leaks within 2 to 3 hours. And that's what normal time the Western blot takes. To run the Western blot, you take 2 to 3 hours. But having a patient in the emergency room and collecting the sample and going to the lab and telling the patient, wait here for 3 hours, I'll come back. It's not a good idea, I think, particularly when the patient is in the emergency room. So what we thought was we should collapse this 3-hour lab test into a collapsible 2 to 5 minute test. And that's what we did with this lateral flow format. I don't know whether we have pregnancy test kits here. Do we have pregnancy test kits? Yes, it's the same format, but we modified it a little bit, and then that's where we went into nanotechnology. One of our chairperson was saying about nanotech. So we actually took gold nanoparticles and conjugated these gold nanoparticles with one of our antibodies, and we have a second antibody against the same protein. We coat it onto this test zone, and then when you put the sample, and if the sample has the marker, this marker will bind to this antibody, and the gold bead will tumble across the strip and then get strapped here, and a red line will appear. It's similar to pregnancy test kit. So imagine if there is a CSF leak, and if you use this strip, in less than 5 minutes, we can know that there is a CSF leak. So using this lateral flow technology, using nanogold particles and antibodies specific for that CSF leak marker, we actually formulated a test strip. And I'm setting the story for this whole thing now going into virus. So we started learning about lots of things about rapid tests. And interestingly, lots of chemists started working with us. Lots of manufacturing people started saying that this will be a good test. So we actually started looking at different particles like gold, silver, carbon, latex, and different types of particles. And we did lots of studies to show that gold and latex are the best conjugates for any marker antibodies. Antibodies can really bind to gold particles. You don't have to do special chemistry. So if you are planning to develop a test against a marker for a viral protein or something, you just need 2 antibodies against the protein, and you are in business to make money. And I'm also emphasizing a little bit about the money here on this forum, because lots of my younger colleagues, I know lots of my students, they always want to get rich quickly. And they always say, oh, as a professor, how much do you earn? I should ask my professor colleagues here. Peanuts, I guess. But science and research is a passion. And that's what they think. Oh, you are earning very little money. I don't want to be involved in science. I want to make lots of money. But at the same time, doing good science can make you a lot of money too. And this is an example which I tell the students. So we started looking at the beads, gold nano beads and polystyrene beads, showing that the antibodies can really absorb to these beads. And we started making prototypes of these test strips. It's like any pregnancy test strip. So we made these prototypes of the test strips, showing that it works. Then comes the real story when we started looking at where can we use this test strip. So I told you that if you have an accident, you can actually use this on an accident victim to show that. So we started looking at different scenarios in the clinical settings where these test strips can be used to detect CSF leaks. Interestingly, we found that epidurals is where CSF leak happens. Anyone knows what an epidural is? Any moms in the audience who delivered babies? When you are pregnant, when you are about to deliver the baby, you are in lots of pain. We give you an epidural injection in the back to numb the pain. Sometimes the needle is pushed too far in and CSF leaks out. We get many cases like that in teaching hospitals where your house surgeons, they don't know how to do the epidural shocks, injections. They push the needle too far, CSF leaks out, and many a times the mom comes back with infections of the central nervous system, particularly viral meningitis. So here is a scenario where you can use a test strip to identify if there are any wet tabs in epidural incidences. And with ENT procedures, that's where CSF leaks happens. Battlefield medicine, interestingly, we went to a defense conference in Maryland, Bethesda, Maryland, and the surgeon of US Army, he came in, Dr. McKenzie, he said that, Srini, I think we need your test strip. And I said, why do you need the test strip? He says that when the soldiers go to war, they encounter these grenade explosions. And when the grenade explodes, they are blown away, and many times they have concussions. When they have concussions, they have small fractures on the skull. And many times these soldiers get viral infections. And he said that if you have a test strip, if you are involved with a grenade explosion, you take a test strip, put it in your nose, mouth, or ear, and if the test strip turns green or blue, you know that there is a break, so you can go and get prophylactic treatment. So this is an interesting scenario where we came across detecting CSF leak can prevent viral meningitis and encephalitis, infections like those. So we developed these tips, and I'm going to show you a few slides about the economics of this. When we start making these test strips, I found a US partner, a Chembio Diagnostics, a company, and they said they'll manufacture these test strips for $3. Just $3. I said I was very happy. And so we went and did the market analysis, because somebody was saying in the morning, Americans are all about money. Unfortunately, it's true. But the money will help also in a way. That was never discussed. So when we went and did the market analysis, epidurals alone, the market in US alone is $45 million. How much did I say the test strip costs? $3. So if I am doing a $3 test strip and I can sell it for $10, it is good science, but it also can give you good money. And then we did another scenario where we did the ENT surgical procedures. Particularly in ENT surgery procedures, if the operating rooms are not sterile, patients will come back with lots of infections. So the ENT surgeon said that they can pay $100 per kit. How much did I say each test strip costs? $3, good. So $100, and there is under $45 million market on this. And here is the head trauma. You're playing cricket, the ball hits on your head. Who knows, there is a small fracture, right? Imagine you taking a test strip and putting into your nose to make sure that CSF doesn't leak out. So the market is huge. All these to prevent viral infections for the central nervous system. And we had a market of 175 million. And Battlefield, the US Army said, yes, we want this in the US Army. They said it can be as big as $200 million a year for test strips. And in Delhi, I met Dr. Bhatto, Colonel Bhatto. He is the chief surgeon for Indian Air Force. We met in a conference and he said that we need it for Indian Air Force. And I didn't have a clue, why do we need it for Indian Air Force? And he said that when the airmen, when the crew were being trained to parachute from heights, when they are new recruits, most of the time they fall on their heads. And they have lots of concussions. So they prevent any viral infections. Further on, they said, Indian Air Force can use these test strips. Imagine the social impact of how small science can help. So there is a big market, and of course neurosurgery is a big market. So we actually looked at the whole manufacturing process. Because I told you one of the companies in US, they said they'll do it for $3. So we thought, okay, why if they're able to do it for $3 and still make money manufacturing a nice test strip, we thought we should do it ourselves. So we set up a small company, that's the business end of it, and we started looking at how the manufacturing is done. It's the cheapest manufacturing business plan anyone can ever come across in the healthcare scenario. To put up a drug company, it's very expensive. To pick up bulk manufacturing, it is very expensive. To put up a in vitro diagnostics manufacturing company in India, it costs less than 3 crore rupees. For most of us, it's a lot of money. But 3 crores in the big picture to make these low-cost detecting devices is the cheapest way to save lives. So we actually I came to India and asked one of my friends, so how much it costs to make this test strip in India? So in US they said it's $3. Here it costs $1, less than $1, 90 cents. So it's so easy to make test strips and to save lives here. And I went to Beijing, China, and they said, outrageous number. Can you imagine how much they charge to make a test strip like this? Here it's 90 cents. In China, they said they'll make it for 16 cents. And we are selling it in the market for more than $100 a test strip. This is the other side of medicine and clinical scenario. But the true side is where you can make sensible stuff with low-tech science using ingenuity. Okay? So with this in mind, we started looking at making several devices, and that's where we really went into the viral field. So we started looking at AIDS, of course, HIV. To detect HIV, how much it costs in our laboratory settings in India? I'm not sure, maybe 20 rupees, 30 rupees? Anyone? How much it costs to detect HIV? 20, 30 rupees, right? Okay. So we thought, okay, 20, 30 rupees, it's less than 10 cents, 20 cents we can make that strip. So we actually made a lateral flow test using the knowledge that we gained by making cerebrospinal fluid test strip. And here is the test strip where we coated some gold nanobeads with protein A conjugated to those. And when the antibodies from your sample binds to this, to protein A beads, they migrate and they go and bind to the test line, and you can see a color coming up. So that's a typical HIV test kit. And I know in some hospitals, they charge 300 rupees per test. Here, I won't name the hospitals. Some even charge 800 to 1,000 rupees if you come in a Mercedes car. That's a different story. But the test strip costs less than 10 rupees to manufacture in India. So we started making these strips, and unfortunately or fortunately, we started importing these test strips to India to detect HIV. And many of these test strips were sold by some of our dealers here. And I'm going to tell you the different story about Indian perspective, how bad we feel about it. And after some time, these dealers started saying that, oh, we don't need your test strips anymore. I thought, oh, HIV is eradicated, you don't need any more of these HIV test strips. But then later we found that the dealers, when they sell it to the clinical labs in small rural settings, they advertise these strips are made in US, is the best strip that can happen to you, and they charge 50 rupees for this. We charge them only 10 rupees. And after the test is done, they actually take the test strip and wash the line with mild bleach and reuse it again. Very, very unfortunate. I'm actually addressing this to the younger generation. I'm in the sandwich generation, I think, in middle, not neither old nor too young. Very, very unfortunate when we found that the test strips in rural areas particularly, these are innocent people who are naive, who don't understand what a test is. But they're scared. AIDS is a big thing for them. When they say hey, you have AIDS, then their lives are gone. And these small rural area clinics, to make money for 50 rupees, they're reusing the test strips. Unfortunately, that's when we stopped doing business in India. And I bet if you go into the rural areas and educate the people, you'll eradicate most of the spread of these viral diseases and the panic associated in the families when you're diagnosed with these diseases. So we came across a different idea, because these test strips can be bleached, washed, and reused again. So we came up with a platform called dual path platform for HIV detection. So here is another way of detecting this. We imagine if you have antibodies in the sample, there are two strips now. Instead of one strip, you have two strips. You can put the sample on this side, and once the sample moves, it comes and binds to the antigens which are coated there. Then we add another sample of protein beads, and then those can go and bind. The beauty about this is, once this strip moves in this direction, everything is coated by a parafilm. So there's like a window which comes, so you cannot go back and try to use bleach to clean the strip. So this is a little bit expensive, but this is a simple device. But you can prevent these sort of reuse of test strips in developing countries like India. I'm not saying India is the only country. We heard many, many rumors in many countries, third world countries, that the strips are being reused. Okay, so we actually developed this test strip, and this is the interior of this test strip. And to tell you the whole story, the cost to manufacture this low-cost point-of-care devices is very cheap. This test strip, which cannot be reused or bleached, can be manufactured for less than 30 rupees in India. Very, very cheap. And imagine the impact it can have on our population to detect HIV or other diseases. So here, and we also developed a fluid collection device where you can collect fluid samples from your nose or oral fluids or saliva, whatever, tears. You can collect the sample, drop it into the well, and in less than 5 to 10 minutes, you know that you can see whether you are HIV positive or not. And we collaborated with another company who make electronic devices. So we are taking a small, low-cost biochemical assay to sort of high-tech device for a very cheap price. So we can actually insert this device into a rapid test reader, and now it will start printing out the results and actually quantify the titer of the virus. You can see how much viral titer you have in the sample by using these electronic plate readers. And so we actually developed these, and also another beauty thing about it is we started playing with multiple test clients. So it's not only one device for one HIV test. We mixed many diseases. We had a test for TB, we had a test for Chagas, we have a test for hepatitis B, and we have a test for HIV. So we combined all the test lines and put into this one DPP platform, so you can, with one shot, with 30 rupees, that's the manufacturing cost, you can detect 4 different diseases in the same patient in the same sample. And the sample you need is less than 10 microliters of either your blood or your saliva or your mucus. And that's the beauty of this devising low-cost, rapid point-of-care devices. So our DPP has lots of applications. It can detect HIV 1 and 2. We can do fingerstick blood, venous blood, serum plasma, oral fluid, and we are now combining these tests. HIV, TB, as you know, they come together most frequently. So in one test, we can actually detect HIV and TB both in one strip format. So there are lots of advantages. We started working with multiple antigens. And remember, the take-home message is, if you want to make a low-cost point-of-care device, you just need 2 things. One, an antibody against that marker protein on one epitope, another antibody of that marker protein on the other epitope. If you want to detect a protein marker, if you have those 2 tools in your hand, you can make a strip for any disease. And for diseases like HIV, you just need one antibody, one antigen. You don't even need an antibody. You just put the antigen on the strip and it will detect your antibodies. The only thing you need is gold nanoparticles. So with these very, very simple things, we are able to manufacture these low-cost point-of-care devices. And now we are working with quantum dots. This is below nanotechnology. They are smaller than nanometers. So by differing the size of these particles at the quantum level, you can have different colors of these particles. So by attaching each color to each different protein marker, you can have multiple detection kits or multiple disease detection device in one strip. So we are using lanthanum quantum dots to actually make strips which can detect multiple diseases. So a good thing about economics about the POC means point of care testing. So you can reduce the number of hospital visits, you can reduce the number of length of hospital stay, you can early discharge the patient from the hospital, and there are lots of advantages of low-cost devices. So we try to go buy Siemens MRI or CT scans or Philips instruments, but think about what we can do with your ingenuity in a very, very efficient, low-cost manner. So with this, I'll sum up by saying that US healthcare, I'll talk about US healthcare here, the market of in vitro diagnostics is almost $30 billion now. It's a huge market. And in India, 3 years ago, I came across this figure, the in vitro diagnostic market is more than 1,300 crores now, 1,300 crores.
About 2 minutes.
I'm almost done. So, and here is in the developing countries by 2015, we believe the in vitro diagnostic markets with simple technologies like lateral flow point of care technologies, which I just mentioned, very simple format, very simple technique. The market for these devices will be more than $48 billion by 2015. And I believe that's where we should work on as Indians. We have the ingenuity. We always argue saying that, oh, we don't have resources, we are not rich. Yes, we are rich, but our population actually diminished the richness. So by using these types of devices, I think we can eradicate most of the diseases and diseases like viral infections. So I told you a story where we came across an operating room setting, trying to see whether there is a break into the CNS. So we identified and manufactured a device. Then we went on using the technology to make devices against HIV. So now we are developing devices for hepatitis B, diphtheria, and we just got a grant from DARPA that we'll be using these monies, these technologies in bioterror detection too. So with this, I would say that tiny technologies, that's what we call nanotechnology, less than tiny technology, quantum dots, is the technology to rapidly detect diseases and symptoms, and this is what we call point-of-care diagnostics or POC diagnostics. So just to let you know, there's plenty of room at the bottom. You don't have to use high-tech devices to detect diseases or symptoms. You can use low-tech devices. So that's why I said that there is plenty of room at the bottom. So in our clinical setting, we always say faster is better. The faster you know the results, the sooner you can intervene and treat the patient. So faster is better. It's really that simple in giving good health care to the patient. So this will be the best example for you to think about, hopefully, to think about developing low-cost detection devices for viral outbreaks. With that, I thank the organizers for giving me this offer. Thank you.
Good afternoon, sir. I'm Shubham from MRITS, and my question is, you have said about the HIV strip. So can we detect the virus after the entry or after the onset of infection?
Yeah, so that's a good question. I also told you how to make these test strips. Either you need 2 antibodies to detect the viral protein, or you need antigens, synthetic antigens, to recognize the viral antibody titer which you have. All the test kits which we have now, they can only detect the antibodies that you produce against HIV. So we are now developing test strips where we can detect the viral protein itself. So you don't have to wait for the incubation period to actually see that you have viral infection. So we can detect, because to see that viral infection, you have to develop your own antibodies. That only the test strip, the current test strips will detect. But now we have a test strip that has antibodies against the viral protein. So the problem is with HIV, you know that it doesn't stay in the blood, it goes into the cells. So we devised a buffer, it's a very simple buffer, where you can take the blood sample, add some lysis buffer, simple 10% SDS, and then you can lyse the cell open and the virus will come out and we can easily detect it. So our test strips can detect at the first day of infection, but the current test strips that are in the market will detect only your viral antibody load, that you mount a response. So that's the difference between these.
Any other questions to later on, and we thank Dr. Kakatiya for this wonderful journey from the clinic to the diagnostic test back to the clinic with the colorful detours through economics and law. From the organizers, we present you a memorandum.
Invite Sunita Reddy to go ahead.
Thank you to Dr. Radhakrishna and the organizers of Virus Outbreaks for giving me the opportunity to be here today for the next couple of days. Okay. We talk about emerging and re-emerging infectious diseases. What does it mean? It means when you have infections that are new and are appearing in humans, which has been unprecedented before. It's appearing in a new geographic territory, or it was once controlled and it's coming back again, or it's an old infection but has changed in some form or presentation, or for example, diseases that are caused because of antimicrobial resistance, which we talk about all the time, which is not going to be part of today's discussion. The typical example I would like to give for this is the disease that caused the AIDS, the HIV infection, which did not exist in the past in humans and was diagnosed in the 1980s. It totally changed the paradigm of how we thought infections work. Okay? Most of the emerging infections, majority of them are vector-borne, about 70% of them are vector-borne or zoonotic. If you look at this slide here, there are plenty of infections, for example, Synombre, Ebola, Lassa, Chandipura, Nipah. Every single one of these listed here are related to vector-borne infections. So That's where we need to collaborate with each other in terms of trying to find out more about how to deal with these problems. Okay. If you go back and see what were the problems that we've had, for example, in the 1970s, we had acute hemorrhagic conjunctivitis caused by enterovirus 70, which was totally new. The virus emerged in Ghana in 1969 as a human bovine recombinant enterovirus. It did not exist before. This is an example of a new agent which went on to cause a pandemic. In the 1980s, this is not a virus, but still, leptospirosis was a major problem. The incidence and geographic prevalence increased significantly, so it moved from one place to the other. It was an old infection, but it increased in incidence. In the 80s, we had dengue, which appeared in the western coastal regions. Previously, the vector that carried the dengue virus, the Aedes aegypti, was not present in the western coast, but it moved there, and along with it, dengue followed. What was previously mostly an urban disease became a rural disease as well. So this is an example of old disease appearing in new places. Move on with dengue again. What happened thereafter? Late 80s, the disease changed its pattern. There was an outbreak of dengue hemorrhagic fever and dengue shock syndrome. And this was first diagnosed in Tamil Nadu, but once it started, there was no end to it. This is what we are scared about when we talk about dengue today. In the 1990s, there was an outbreak in Delhi. And once it hits the capital, everybody pays attention to it. So that's what changed there. 2003, another huge problem in Kerala. Again, because of this change in the way the disease presented, it was not diagnosed early and a lot of lives were lost thanks to that. So this is an example of an old disease, but new presentation. Okay. In the 1980s, we had the HIV infection, initially diagnosed in women with sex trade in workers of Tamil Nadu. So this is a new agent and went on to become a pandemic. Okay. But if you look at more evidence, it was probably there in India even before that. Okay. And this is a huge example what we can take in terms of how we can try to control infections, and we've learned a lot of information from HIV pandemic throughout the world. It has now the numbers are actually going down with regards to HIV. Why do we have all these problems? Many reasons. Urbanization and destruction of natural habitats. So what happens? People move from their original habitat and move into forest areas, and we move towards animals. And there's more contact between humans and animals. That leads to climate change and changing ecosystems. So there's more and more changes that happens with the animal kingdom as well. The changes in population of reservoir hosts and intermediate insect vectors occur. And along with this, there's also a concept of microbial genetic mutation, which we talked about antigenic drifts and antigenic shifts. Viruses keep changing. The SIV virus in the chimpanzees became the HIV virus in humans, and so on. So there are many emerging and re-emerging diseases which are of zoonotic origin. Diseases has emerged from animal and crossed the species barrier to infect humans. Approximately 60% of all human infectious diseases that are recognized so far are probably from animal origin, and 75% of emerging infectious diseases that have occurred in the last 3 decades have originated from animals. So the impact of emerging infectious diseases is relatively greater in developing countries that have fewer resources. In the past 30 years, more than 30 new infectious diseases have emerged. Asia is often at the epicenter. So, what are the diseases that we have seen in India? Plenty of them. We will go through some of these in this course of the next 15-20 minutes. We'll start off with the Chandipura. The Chandipura virus is an enveloped RNA virus and belongs to the genus Vesiculovirus of the family Rhabdoviridae, transmitted by sandfly. It almost was an orphan for a long period of time. It was never thought, the existence of the virus was known, but it was never thought to be linked to any human infections because it causes a very indistinct clinical pattern. It's been isolated in multiple countries and continents from Africa to Sri Lanka, and can affect multiple mammalian species. However, human cases have only been reported in India. The first isolated case was in 1965 in Maharashtra. Later, it was diagnosed also in Raipur. But it came to notice in 2003 when 329 children in Andhra Pradesh had an outbreak, and 55% of them resulted in death within 48 hours of onset. Just imagine 300 children dying within 48 hours of falling sick. And then the next year in Gujarat, there was another outbreak where 78% of the children who developed the infection died within majority within the first 24 hours, and a lot of them within the first 4 days. Fortunately, the last outbreak we had is in 2010, and again in Gujarat. So far, not too many outbreaks as such, but we still have had a few sporadic cases here and there. How do the people present with? Fever, altered sensorium, convulsions meaning fits, followed by vomiting and diarrhea. Some evidence of neurological disturbances can be there, and but however, most of these neurological disturbances are not present in survivors. So if you live through this, you can survive normally. So this outbreak of Chandipura virus has been given a new name called epidemic of a brain attack of childhood, or the Chandipura encephalitis. So this is a picture of a couple of children who had been affected with this virus, and this is the area where the virus has been present. Okay. Next, we move on to the next virus that we're going to talk about, which is the Nipah virus. Nipah virus is also a single-stranded RNA virus, and along with Hendra virus are closely related viruses which belong to the family of Paramyxoviridae. Reservoir for this is the fruit bats, and Nipah virus does not normally cause infections in humans. It typically affects the fruit bats and then go on to affect the intermediate host, which is the pigs. Pigs are the major source of infection to humans. Are you familiar with how pig handlers work, the abattoirs? Basically, they keep running behind the pigs trying to hold them. So if pigs are infected with these viruses because of the close contact with the pig workers have with the pigs, that leads to the infection in humans. And this is what has led to an outbreak in Malaysia. So Malaysia, where pig workers had major outbreak, and then they said they had an outbreak in Singapore. Actually, that outbreak in Singapore, fortunately, was a single patient that was identified early and was contained. The outbreak was contained. This is a highly infectious virus. The clinicians' judicious history-taking and ability to diagnose this as not a usual infection and look for what is the problem led to the arrest of the outbreak with the single patient that was affected there. Subsequently, it has been reported in multiple places, including Bangladesh, Australia, Thailand, Cambodia, and we've had this problem in India. So this is what happens with the Nipah virus. Typically affects the bats, can affect animals, and we become usually a dead-end host, but can also spread to other contacts. Symptoms of this infection, again, okay. When you have human cases are typically from animals, usually pigs is the most common one, and person-to-person infection has been documented because the virus is spread through the is shed in the respiratory secretions and the urine. Incubation period is typically 5 to 20 days. When I talk about incubation period, it means the time from contact from the virus had with your body to you developing symptoms. Typically what happens with this infection is you inhale the virus enters through the nose, affects the, enters the nerve that supplies the nose, that's the olfactory nerve, and from there goes into the nervous system. And that's the reason why people develop CNS disease, which is basically fever, altered sensorium, confusion to coma, can have headache, myalgias, and eventually a lot of them have seizures and eventually die of this infection. Between 1998 and 2012, there were 15 outbreaks reported in India with a total of 524 cases, and case fatality rate was 56%, which means 56% of the people who had developed this infection died, and sometimes can go up to 100% also. there was an outbreak that was occurred in Siliguri, which was evaluated a lot, and studied well. So here in this case, they found that the case fatality rate approached 74%, which is much higher than what was reported in Bangladesh or in other countries. So, like Malaysia and Singapore. So there's thinking that probably the virus in the Indian subcontinent, which is India and Bangladesh, is probably more virulent than the one that is present in the other countries of Southeast Asia. So this is somewhere that more research is required. And the issue we have here is we have a lot of natural reservoir present in the northeast part of the country in terms of the availability of bats. And the virus has spread from the northeast part of the country and has also reached at least as far as Haryana. And so there is a possibility that we may have future outbreaks of this disease. How do you diagnose this disease? Again, this is a highly infectious virus, so it is recommended to have a very high biosafety lab. So not all of labs can deal with this. You need a biosafety level 4 at least because of the high fatality rate of this infection. And ELISA is the one that is used for diagnosis for antibodies, and you can also use an RT-PCR of the urine sample. Immunofluorescence assay or virus isolation from cell culture can also be used, but again, when you're talking about such a highly infectious virus, these are not tests that are used for clinical practice. No approved drugs for this. There have been some trials, but at this time, the main thing is to contain the symptoms and the neurological symptoms. So move on to the next infection that we're going to talk about today, which is the hantavirus. Hantavirus is a single-stranded RNA virus belonging to the family of Bungiaviridae, and it's also again another zoonotic infection through rodent-borne virus. It is a tri-segmented genome which codes for a replicative enzyme and has a nucleic acid protein which is abundant and highly antigenic. And recent data suggests the presence of hantavirus in infections in India, but its details are not completely known. And it's probably underdiagnosed in India because of the lack of awareness and also because of the lack of diagnostic facilities for this infection. We have suspected hantavirus in our clinical practice multiple times. Unfortunately, it just goes as a clinical diagnosis. It's difficult to prove it. In fact, at one point of time, I think a year or two ago, there was one case that was reported as hantavirus, and the government came down big time and said that how can you tell that it's hantavirus when you don't have an approved lab to test for it? So that's an issue. We need better diagnostic facilities. Maybe Dr. Penchala can see if he can help us with some of these infections as well. So man can get infected through aerosols generated by from virus contaminated with either rodent urine or feces. It's a rodent urine feces that is one that has this virus and that it can spread. Incubation period ranges from 1 to 5 years. A lot of times you see patients coming with the symptomatology suggestive of hantavirus post-monsoon season, because that's when people wade through water, and that's the time when your sewage is mixed through rainwater and your roads are flooded and you're walking through that. That's one time we see some of these kind of syndromes. Major manifestations are usually non-specific, but it has 2 clinical syndromes that can occur, which are severe hemorrhagic fever with renal syndrome, which means hemorrhagic fever means you're bleeding from your body because your blood counts are very low, particularly the platelet counts drop very low, and renal syndrome is where your kidney is affected. And also you can have something called a pulmonary syndrome and a cardiopulmonary syndrome along with the above, where your heart and lungs are affected. And here death is because of cardiac failure rather than basically because of cardiac failure. Again, in 2007, following the floods in Mumbai, there were a few cases that were reported, like how we were talking about earlier. So this is a picture of what are the disease patterns that can be present. People can present with hypotension, which is low blood pressure, serositis edema, where your fluid is leaking outside to your path where the fluid is not supposed to be. Abdominal pain, dialysis requirement, which means your kidney is affected and you're bleeding from the eyes and elsewhere. Okay. the diagnosis is basically based on the nucleocaspid protein, which is present in abundance and it's highly antigenic. And you can use IgM antibodies for this one as well. RT-PCR is real-time PCR is also a very good test in the acute stages. Again, there is no definitive treatment. This is a picture from the news clipping where when we had an outbreak that was suspected in Chittoor districts, where people who were rat and snake catchers, again because they're handling rodents, there were some cases reported in 2008. We move on to the next, SARS. Again, I'm not going to go too much into SARS because it didn't really come into India, but briefly, SARS is a coronavirus and it can cause animals in humans and cause infection and disease in humans and animals. And there can be symptoms of fever, cough, breathing difficulties, and pneumonia. And sometimes you can have diarrhea and worst cases respiratory failure. A lot of cases reported in, from multiple viruses of multiple countries. Again, this is the MERS-SARS data. And we did not have much of this here, but outbreak is still being reported. In fact, I think yesterday there was a report of another patient dying of MERS in Saudi Arabia. Bigger problem when you're having people going with Hajj to these areas. The next one is Kyasanur, and I'm not going to talk about it because there's a separate talk on this by another speaker in the rest of, during the course of this conference. HTLV is an infection that I have seen at least about 6 of these patients. I'm reporting one of this here today. 35-year-old lady who had a complicated obstetric history. She had been going through infertility treatment for several years, had failed multiple IVF is in vitro fertilization, and now finally had a normal pregnancy, delivered, and comes to me 6 weeks post-delivery. Why did she come to me? Because she had given cord blood for storage. How many of you are familiar with what is cord blood and storage about it? Okay, I think there's some people who know about it. Basically, you're taking the stem cells from the placenta and you're storing it for possibility of a use for future, either for yourself or your family members or for anybody else, in case we have more information about stem cell research for the future. So what do they do when they take the stem cells? The lab that stores these stem cells tests the stem cells for cord blood for various viruses. It includes HIV, hepatitis B, hepatitis C, CMV, and HTLV. Patients come to me, or they're not really patients, the parents come to me because the lab has reported that this HTLV 1 and 2 is positive. So what do you do at this point? Why are they so scared about it? Because HTLV can cause big time problems. For example, it can cause something called adult T-cell leukemia lymphoma. It can cause tropical spastic paresis and a lot of multiple minor issues. But when someone tells you that, okay, you have this infection in the body and you're probably going to have a leukemia or a lymphoma. Look, that's a blood cancer. What are you going to do? Panic. Okay? So that's what happens when these people come. So when they came to me, I started doing literature search and trying to figure out what is happening. You look at the literature. All the literature tells you is there is no HTLV in India. This is one study. And there's one more actually, I didn't put the other study here. Another study which also says that they've screened about 10,000 samples of blood donors and they have not seen HTLV. So what does it mean? We really don't know. This is where we need more research. Okay? But we have had patients who have HTLV associated lymphoma and leukemia as a disease. We are not routinely screening blood products or organs for HTLV today because the assumption is that HTLV does not exist in India. HTLV is a virus that is present predominantly in countries like Japan. Even in the US, they're not screening, the screening is, some centers do it, some centers don't do it, it's not fully uniform because it's too much of a cost for such a less incidence. So in India, we don't routinely screen. There is no standardization. This is something that I would like to throw at scientists sitting in this room to see if we can come up with a system whereby we can know more information about HTLV. Okay?
Sunita, I have 2 more minutes.
Yes, I'll be done. JE virus I'm not covering here. West Nile virus is similar to JE virus in the sense of clinical spectrum. It's a member of the Flaviviridae family. It causes encephalitis. Initially diagnosed in Uganda but went worldwide. We have known about its presence in India for ages. It mimics Japanese encephalitis. We have seen antibodies for West Nile virus in an outbreak in 1982 in Tamil Nadu. We've seen cases in Collages district, but again not routinely looked for. In Assam, when they were evaluated to see if all that they were seeing of encephalitis was JE virus or West Nile virus, a significant proportion of this turned out to be West Nile virus. Okay, so chikungunya again I'm not going to cover here. Dengue I'm not going to cover. Flu, I'll skip this because we already read about flu. Crimean Congo virus is another viral virus that is transmitted by ticks and known to cause human infections. It's transmitted by the Hyloma ticks. It's been present in most of the Indian and European countries. Affects people who work with livestock and agricultural workers. Has been present in India for a long time in Jammu and Kashmir. And antibodies have been detected in people even in South India. And we have had an outbreak in 2007 in Ahmedabad. And Pune has done some studies and they found that we do have this disease in India. And I will skip these slides a little bit. Okay, so Crimean Congo virus affects the macrophages and dendritic cells, causes hemolysis and causes hemorrhagic fever, affects the liver as well. Okay, last 1 minute I'll take for vaccine-derived polio. We just talked about polio being eradicated and we use the oral polio vaccine for vaccination to prevent polio. Oral polio vaccine is a live virus. We all know that live viruses can potentially give rise to infections as well. And oral polio virus vaccine can undergo deattenuation and can cause sporadic epidemic polio. And this is something that we have known all along. And we've had several cases of vaccine-derived polio throughout the world. It's not used in developed countries, we still use it. And we've had cases of vaccine-derived polio in India. If you look at the next few pictures, the red and the blue are all wild-type virus causing polio in 2009. You see a little bit of vaccine-derived polio. When you had so much of wild-type virus, it didn't matter, I guess. But as you go along, the wild-type virus decreased and you're left with only vaccine-derived polio. So, is it time for us to change from oral polio vaccine to injectable polio vaccine, which is a killed vaccine? It's a challenge to the government. We have to put it across and see if we can move on. So, these are changing paradigms of infections. So, what do we have to do? What are the issues we have? We have two public health systems. One is the healthcare and one is the public health. Healthcare is when you go to the doctor as an individual, it's a one-on-one thing. Public health is when the government, where a public health department works for the community and the environment. In the healthcare system, the doctor is focusing on the individual, trying to diagnose that patient, treat that person, try to do preventive care. Whereas in the public health, you have to do social justice and try to do build up the public sector to help prevent diseases in the long run. Okay, so this is where we need to really work on a strong public health system with established communication between the animal health, agriculture, forestry, health sectors at national, regional and global levels to combat the emerging and re-emerging viral outbreaks. And this is hopefully a start for this process. Thank you.
And 2007 Nadia in West Bengal, just on the border of Bangladesh. It is not Nanded, it is written somewhere Nanded. Nanded is in Maharashtra.
No, it should be West Bengal.
Yeah. And then second thing is that when this particular list of diseases, we have say totally socio-economic setup which is different than all Western countries or developed countries. And probably we cannot eradicate these systems so quickly, at least.
Absolutely.
Yeah, and then we have to find out solutions in the presence of these systems. Thank you.
Tomorrow and day after tomorrow. Poster presentation PP1 to PP80. You will have to display your posters on 21st, that is tomorrow from 10:30 to 11:30 a.m. On 22nd, that is day after tomorrow, that will be from 11 to 12. And the poster presentation would be near the lunch counters. The boards will be allotted to you then and there itself, so please come prepared for your poster presentation. And coming to the cultural events, I hope all of you have gone through the program schedule that has been printed in your souvenir. So as per the program schedule, tomorrow evening we are having cultural events. Delegates who are interested in participating, that is those of you who are interested to give a dance performance or any other talent you want to present it on stage, please come and give your names to me. I am Soumya. I'll be available here only. Please come and give your names to me. Thank you.
Yes, ma'am. We have introduced 2 years back. We have introduced. I'll come down, ma'am. So, take my other than.
Hello? Hello? Okay. 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 Yeah, you make a message, madam, about your travel plan. Okay. Okay, Kachiguda. At what time it is coming? Yeah, you get down there in Kachiguda only, but let me know the timings.
No.
Okay.
Yes.
Okay, this is your number, no?
Yes, sir.
Your name, good name, madam? Sandhya.
I welcome Dr. M. Rajarao, Professor of Medicine from Fever Hospital, Hyderabad, to deliver his lecture on the overview of viral hemorrhagic fevers and clinical scenario and management of dengue fever.
Global warming or increase in international tours and travels, increase in excavations and explorations of the forests. So we should have a broad area of the viral hemorrhagic fevers. We should not think that this disease is not there. Because Madam previously told that hantavirus, when we talk about hantavirus, no, how can you talk about hantavirus? It's not there in India. We are not unable to detect the viruses because we think that that virus is not in our area, right? So nowadays these viruses, they're crossing the boundary, we should think that point. So here we have to know 4 things. How the virus transmitted in its natural cycle, through arthropod or direct transmission or unknown. And how do human index cases get infected? By an insect or directly or unknown. And is there any nosocomial transmission? And is there any specific antiviral treatment? These things should be known. Dengue being a endemic disease in India, And there are a lot of misconceptions in treatment and even diagnosis. I want to discuss in detail about the dengue fever. Coming to the viral hemorrhagic fever, there are 4 viral families, mainly Arenaviridae and Filoviridae, Bunyaviridae and Flaviviridae. And for this, coming to the Arenavirus, Arenaviridae is the family, Arenavirus is the genus. In this, Lassa, Julin, Machupo and Guanarato, these are the viruses. This Lassa fever is caused by Lassa virus, this is in West Africa, spread by Mastomys rodents. It's a direct transmission from rodent excreta. Human to human spread will be there and mortality is 2 to 15%. And we can use ribavirin, antiviral drug in this. And when coming to other viruses like Argentine hemorrhagic fever, Bolivian hemorrhagic fever and Venezuelan hemorrhagic fever, here also the human to human spread is there and direct transmission from rodents, excreta, and the mortality is a bit high, 15 to 30%. And here also we can use ribavirin. That means in Arenaviridae there is antiviral treatment, ribavirin we can be given. And coming to the filovirus, which includes Ebola and Marburg virus. Nowadays, this Ebola virus is causing a devastating epidemic in Africa. This is mainly important because the natural history of it is unknown. And there are so many suspicions are there about so many animals are, studies are going on, but still the natural history is unknown. And there is nosocomial. And one more thing is no antiviral treatment and there is no vaccine till now. And coming to the Bunyaviridae, here the main viruses are hantaviruses and nairoviruses and phleboviruses. Coming to hantaviruses, already Dr. Sunita has discussed there are 2 types, hemorrhagic fever with renal syndrome and hemorrhagic fever with pulmonary syndromes. It's seen in Far East and Europe and even Asian countries also. And spread by rural rodents and transmission from rodent excreta. And here there is no human to human spread and mortality is 1 to 15%. In severe disease we can use ribavirin. And coming to nairovirus, and here helophatic and livestock, the natural history is because of these things, and mosquito and direct transmission from blood of infected animals. Human to human spread is there here, and mortality is 15 to 30%. And here also we can give ribavirin. Coming to phlebovirus, Rift Valley fever, which is seen in Africa and Middle East, eats and other mosquitoes and livestock is involved in the natural history. And human to human, till now not documented, but it's possible. And most of the cases, coming to Flaviviridae and the flaviviruses, there are so many diseases, important diseases which are seen even in India, like dengue, yellow fever, Osmania fever, Western forest disease. Here there is no direct transmission except Osmania, and there is no antiviral treatment for this. So the main pathophysiology for all viral hemorrhagic fevers is the same, almost similar. So there will be vascular damage, because of that there will be capillary leakage. And there will be disorders of coagulation. It may be antibodies towards the platelets, or it may be platelet dysfunction, or it may be coagulation mechanism. And immunological impairment. Because of the immunological impairment, the virus will replicate fast and causes devastating disease. And endocrine damage. Endocrine damage can be a direct effect of the virus, or it may be because of the plasma leakage. And coming to the dengue fever, and it's a common parvoviral disease and spread by Aedes mosquito. The only known vertebrate still now is the human. And dengue is an acute self-limiting disease characterized by fever, severe headache, muscle and joint pains, rash, nausea and vomitings. There are 4 serotypes. Dengue virus 1, serotype 2, serotype 3, serotype 4. And nowadays there is, because of the